Welcome, colleagues. We're here for a focused clinical update on a condition I know we all see, Incontinence-Associated Dermatitis, or IAD. We're going to jump right into the latest on how to prevent and manage it.
First off, a special thanks to Dr. Abdul Karim for making this session possible. Just a heads up, this explainer is really geared towards diploma-level providers. So please, jot down any questions you have. We'll have a Q&A at the end to really dig into the details.
So why are we focusing so much on IAD? Well, get this. A 2020 study found a prevalence of 56.2% in adult patients. That's staggering. This is not some side issue. It's a major clinical challenge that really needs our full attention.
Okay, here's our game plan for this session. We'll start by talking about just how big this IAD epidemic is. Then we'll get into the science of what's happening to the skin. After that, we'll sharpen our assessment skills, look at the latest tools for management, and finally, talk about a big shift towards being more proactive.
So let's dive into our first section, really understanding the scope and the impact of what I'm calling this hidden epidemic.
At its core, IAD is really a specific type of contact dermatitis. It's an inflammatory reaction, plain and simple, caused by the skin being exposed to irritants in urine or feces for too long. Clinically, you know what it looks like. Redness, a rash, and of course, our patients report a lot of discomfort, itching, and pain.
And this quote just says it all, doesn't it? It nails the clinical reality. As Atlee and Serene pointed out recently, managing IAD is not easy. It takes up a ton of resources, and it puts a huge burden on our patients, on us as staff, and on the whole healthcare system.
Okay, so that leads us to our next section. Let's go beneath the surface and really understand the pathophysiology here. How exactly does the skin barrier break down on a microscopic level?
So, the skin's first line of defense, and it's a brilliant one, is its acid mantle. Healthy skin keeps a slightly acidic pH, somewhere between 4.5 and 5.5, and that acidity is absolutely critical for keeping harmful bacteria and fungi out. Now here's where things start to go wrong, and it really happens in 3 stages. First, that prolonged moisture overhydrates and softens the outer layer of the skin. Then, all that wetness starts to change the skin's pH, which neutralizes that protective acid mantle. And finally, with the defenses down, irritants from urine and feces can get in, leading to total barrier failure, and that inflammatory response we call IAD. Now we get to what is, in my opinion, the most critical clinical skill we have: developing an expert eye for accurate assessment and diagnosis. The literature is crystal clear on this. The first step, the most crucial one, is getting the identification right. We have to be able to tell IAD apart from other skin issues, especially its most common and dangerous lookalike, a pressure injury.
This is where that expert eye is just so essential. So let's compare them side by side. With IAD, you're looking for a widespread redness, often with scattered, irregular borders, and the skin might even look a little shiny or glistening. And the key is its location. It's always in areas that come in touch with moisture. Now compare that to a pressure ulcer. That's usually a very localized injury right over a bony spot, with really distinct edges, and often it involves damage to deeper tissues.
This picture is a perfect example. See that characteristic widespread redness, that rash spreading across the buttocks? That presentation is totally consistent with moisture exposure, not a focus point of pressure.
And the good news is, we don't have to rely just on our eyes. We have some great validated tools to make this more objective. The IAD, for example, lets us systematically score things like redness, skin erosion, and any signs of infection. Then you've got the IADS, PAT, and of course the Braden scale for assessing overall risk. It's an essential toolkit.
So, once we've got an accurate assessment, we can turn to our fourth section, the modern toolkit of evidence-based strategies for managing IAD.
The evidence really points to a structured approach with a few key parts. For cleansers, we need something pH neutral, no rinse, and moisturizing so we don't strip the skin further. For protectants, we have a range of options, from your classic zinc oxide creams to more advanced films that create a clear, breathable barrier. And for really severe cases, we can even use techniques like the crusting method, layering powder and a spray to make a protective seal.
So we've got this effective toolkit for treatment, but the fact that the prevalence of IAD is still so high proves a really critical point. Just reacting to the problem isn't enough. The whole clinical paradigm has to shift towards prevention.
And that brings us to our final section, and that big paradigm shift, moving away from reactive treatment and towards proactive prevention, which is being powered by some amazing innovations in real-time monitoring.
Let's look at a specific case study that used something called the Monit Smart Diaper Sensor. It's a pretty simple device, actually. It just attaches to the outside of a diaper, detects moisture in real time, and then sends an immediate alert to a caregiver's phone telling them it's time for a change.
And the visual evidence here's, well, it's just so powerful. On the left, you see the patient's skin after a week of standard care, and the IED is clearly getting worse. Now look at the right. This is after only 2 weeks using the smart sensor to guide care. The improvement is dramatic. You can see the skin integrity is so much better, the redness is resolving. It's night and day.
And this graph gives us the hard data to back up what we're seeing. The standardized assessment scores just plummeted. The IADS severity score dropped from 18 all the way down to 1, and the PAT score was cut in half, from 8 to 4. I mean, that's the quantitative proof right there that this intervention works.
So the main clinical lesson here is completely clear. Minimizing how long the skin is exposed to irritants is absolutely the key. And technology that prompts us to intervene in a timely way is what makes real prevention possible.
Okay, so this brings everything we've talked about together into a simple evidence-based protocol. Step 1, cleanse the skin gently. Step 2, protect it with an effective moisture barrier. And step 3, the real game changer, monitor. We have to start using technology to get those real-time alerts that drive preventative care.
And that leaves us with a final, pretty provocative thought to take back to our practices. With these new proactive tools, can we actually move beyond just managing IAD to a future where we can effectively eliminate this preventable harm for our patients? Thank you.